welcome everyone to our Thursday Informatics conference. And I'm pleased to introduce our speaker, Dr. Michael Chen, who he came by to visit me and telling me about some interesting work that he's doing. So I said, why don't you come give a talk? And so that's what he's doing today. And it's also interesting coming on the heels. Some of you know I spent the last few days at the HIMSS meeting, the big industry trade conference. And in fact, I could actually still be down there today, but I wanted to come back for this. I think the world is kind of coming around to the vision that we're going to hear today of patient-centered, patient-controlled data. One of the speakers was actually the new CMS administrator, so CMS, the payer for Medicare. And they actually announced, well, they didn't give much details, but they announced this new My Health eData initiative that will enable people to presumably get better access to their data and share it with other healthcare providers and others. And of course, there's these other high-profile projects like the Apple being able to download your Epic data into your Apple Health app. It gives me great pleasure to introduce Dr. Chen, who's actually a practicing family physician here in Portland, works at Portland Clinic and also Paladina Health. Maybe he'll tell us a little bit about that. I don't know a real lot about it. But he also spends his time developing software with the orientation of this patient-centered approach. So rather than I trying to explain it, I'm going to turn it over to him. There are, as we stream this, there are people out there listening. If anyone has a question, just tweet it with the hashtag DMICEConf, DMICECONF, and I'll kind of keep an eye on it. And any of you who have questions can ask as well. So take it away, Mike.
Thank you for allowing me. Sorry. So I'm a family physician working at Paladina Health and the Portland Clinic. And Paladina Health is a direct primary care clinic that serves patients where patients pay a monthly membership fee. We don't bill insurance. So it's a different type of primary care, one where we have more ability to spend more time with our patients, manage patients, not just in clinic encounters, but also through patient portals and phone consults without having to deal with billing and stuff like that. So that's a little bit about what I do currently. I also happen to work on a volunteer basis on an open source electronic health record project that that deals with this patient-centered longitudinal health record. So I'll kind of go through the overview and some of the questions that I was thinking about when I was trying to figure this out. And I work with another physician who is based in Massachusetts. His name is Dr. Adrian Gropper. He's well known in health IT circles in terms of patient privacy concerns. He also used to run an open source medical imaging or radiology imaging service. And so I've been working alongside with him in terms of open standards and open sourcing these ideas that I'm going to be talking about today. Feel free to ask questions, and hopefully we'll get to answer most of them at the end of the session, but if you have any questions along the way, please let me know. So I'm going to talk about today some of the challenges that we're facing today and some key technologies that Dr. Hirsch kind of hinted at, things like FHIR. I don't know if you guys know about FHIR. and including some things like blockchain, which is part of this component, if you will, of this project. And I'm going to talk about the proposed solution that we are making, and then opportunities for questions and discussion. So firstly, I want to talk about the challenges. So I want you guys to imagine being as a patient, how do you, as a patient, make sure that your records are up to date in front of the physician that you're seeing? Now, if you're in one institution and everyone's on the same system, that's great, but there's also quite a few patients that see physicians from different groups. And what if they don't have Epic? What if they don't even have an EHR? How do they make sure that these records are up to date and current? So that's one of the key questions. And even today, even though organizations are doing a much better job of coordinating care technology-wise, there's a big gap that we must acknowledge. So in terms of different specialists and different needs, in terms of what belongs on the health record and what gets filtered out, those are things that are some challenges too, because it's not like a one-size-fits-all type of electronic health record system that we're talking about. And then lastly, we also want to talk about just consumer health apps or wearables. Where does that data going? Is it going to the physician? Does the physician get to see it? Are they utilizing? Are they ignoring it? Where does that go? And where does that fit in from a patient perspective who is wanting to be engaged? And currently, right now, there really isn't a good answer of where that data is going to. And then lastly, I wanted to also talk about patient privacy and consent. Now, we know about HIPAA, and HIPAA is an agreement that a patient signs with an organization that they are working with or a clinic. But we also are acknowledging that there are gaps in terms of where does that data go, once it's what's in the organization. What if there's another third party that wants to get non-identified healthcare data? Where does that go? What are the provisions for that? Some of those are theoretical, but some of them are concerns and concerns in terms of security too, in terms of organizations having a large amount of patient data and hacking and the vulnerability of that data. And then lastly, who owns the patient's health care data? Is it the patient? Is it the organization? And so those are some of the things that that I wanted to talk about here. And right now, I think, in my opinion, patients are kind of spectators of their healthcare data. Some of them take it upon themselves that they organize or they aggregate their healthcare data on their own, but it's a lot of work, and it may or may not be accurate either. But I think currently, right now, I believe patients are still kind of out on the fringe, if you will, in terms of how they really own or have control over their healthcare data. And then from a physician standpoint, some of the challenges that we acknowledge or know about is that there's physicians who are dissatisfied with user interfaces with EHRs. Certainly some EHRs are better than others, but there's a wide gamut of satisfaction or dissatisfaction of user interfaces, and how do they have a voice in terms of improving their workflow? And then we talked a little bit about how do physicians communicate with other physicians within the organization or outside of their organization. And this is what we talk about interoperability and the lack thereof between certain systems with others. And then in terms of point of care decision support, some EHRs do better than others, but some of them don't have it at all. And how do we make the technology that we have useful for the physician, and then also for the patient as well? I think there are some opportunities there that are not really being utilized at this point. And then we talked a little bit about this before in terms of data security, database breaches, ransomware. And then the whole idea of health information exchanges, challenges with that. So patient matching is the biggest one that a lot of the exchanges are having issues with, Then data integrity, whether one organization has one set of data, the other, another organization has slightly different data. Which one is the right one? Where's the patient involved in that decision making, or their care physician? De-identified patient data, and how does that get to be useful or not useful for the patient in terms of patient feedback? And then things like vendor lock-in. Certain organizations have spent large amounts of money on their EHR systems because of meaningful use, and where do they, what are their options down the future as technology becomes, evolves. And so that's also another concern. And then lastly, walled garden technology and silos, where EHRs are kind of trying to encourage other clients to use their same EHR, but still the other, if another client uses a different EHR, are they talking to each other? So now I'm going to talk a little bit about some current technologies that exist right now, and some things that kind of have converged, if you will, that have led to our ideas with this project that I'm going to be talking about. So one of them is something called OAuth 2. I don't know if you guys are familiar with that, but that is something that, for instance, Google, when you sign on to Gmail, they can connect to another app that uses Google for their sign-on authentication. And basically, that technology allows you to just remember one password, which is the Google password, to get onto various different sites if another site utilizes that. Now we've also are seeing a huge explosion in cloud computing and virtual machines and technologies such as Docker that are able to deploy microservers, if you will, that utilize very low resources, operate using Linux as an operating system, that primarily functions as a web server. And then blockchain, the big B word that everyone talks about, and that's new, and how does that fit in with healthcare? And so for us, what we're going to be talking about with blockchain is how blockchain can be used for self-sovereign identity. I don't know if you guys know what that is, but essentially it's essentially a situation where you as a person can present yourself as an identity without having a federated or an organization saying and vouch for you, essentially. You have basically have claims, if you will, from different organizations, and if there's a match for all these claims, then a service or a login or a service can log you in without needing something like some other client like Google, for instance, being your authenticator. And then we're also talking about using blockchain as a way of a public ledger. And that's one of the big things about blockchain is the establishment of trust amongst parties that normally may not have had a relationship with each other, but to establish trust that the blockchain is essentially a public ledger that says that this particular transaction occurred at this particular time, and it's non-repudiable, and so essentially we're talking about blockchain as a way to notarize certain transactions. For instance, in this project that we're going to be talking about, we're going to use the example of writing a prescription, a physician writing a prescription. And then also now with the emergence of certain open standards. So FHIR I talked about earlier. We're also using something called UMA or UMA, which is User Managed Access, which is essentially an offshoot of OAuth 2. And a work group that is currently that I and Dr. Gropper are part of that is working on setting certain open standards, if you will, of these types of technology transactions. And then, of course, using open source technology as a way to encourage peer review of the code for this patient-centered health, longitudinal health record. So any questions before I proceed? I know there was a lot of stuff there, but hopefully that makes sense. So what I'm proposing today is a situation where we're talking about a distributed network model. So rather than a centralized network model where, let's say, an organization like OHSU has their EPIC records, and that's essentially a centralized record where everybody else kind of feeds in data into Epic. What we're proposing is a distributed network model where we have what we call patient containers. So essentially a web server that's in the cloud that's all owned and operated by the patient. And we call this HIE of 1, which is the link is over here that has information to the code at the GitHub site and what we're talking about here in more detail. And so what makes HIE of 1 unique is that it's actually two integrated components. One of them is an EHR that has been designed and engineered as a single patient EHR. So rather than what we think of EHRs now as an EHR that serves thousands or millions of patients, basically this EHR only has one patient, and we have potentially many providers that feed in or feed data into this patient health electronic health record system. And then we have the second component being the authorization server, which functions as an OAuth 2 server. It functions as an UMA server and sets policies that are dictated by the patient when they launch their container about who has access and who has the ability to write or read their health record information. And then both of them utilize blockchain technology in certain operations for authentication, for notarization, for instance. So this EHR component, I talked a little bit about that already. I kind of jumped the gun. The EHR that is being used for this project is called NOSH, this is how I got involved in the project, because that was the program that I created back in 2009 when I had a solo practice back then, and I created an open source electronic health record that's web-based, and that can be utilized both on desktops and smartphones and tablets. And so that was one of that project basically got converted, if you will, into this patient-centered health record because it had an existing patient portal as a part of this program. The EHR is device agnostic, meaning like it doesn't matter if you have a Windows computer, a Mac computer, or a tablet. You can utilize this EHR from any device. And it was designed from the get-go, from the foundation, to be able to process and produce FHIR transactions. And this is the key part of what makes this EHR, this patient-centered health record, to be able to communicate from itself to other organizations. And it already has ways to, like I mentioned before with the patient portal, has a secure communication component for patient and physician communication. And the EHR also generates automatic notifications to authorized physicians for any changes or updates to the patient health record. Now with the authorization server, again, it's also web-based, it's device agnostic. It works as a single sign-on entity, like I mentioned before, and therefore the patient does not need to remember different sign-ons to get to their EHR and their authorization server. And the authorization server allows physicians to use the self-sovereign identity project, which that utilizes blockchain, which is a separate project from us, but we're using it as a test vehicle. It's called UPort. Theoretically, a physician could, with their smartphone, if they have their UPort app installed, essentially they can go to these services, and if they have enough claims to say, okay, I have an MPI number, I have a medical license in the state of Oregon, then a physician could theoretically introduce themselves to a patient's authorization server. And if the patient has already dictated policies saying any physician in the United States that has an MPI number, that has a valid medical license from any of the 50 states, could log into my system, even though I've never stated specifically this particular doctor has to go in. Now they could, but they could also set a default policy that's based on these claims. And that way, you know, if you can imagine a patient that is out of town, they get injured, they go to an ER, and this ER physician could theoretically get to their health records from OHSU, and from their primary care doctor from the Portland clinic without having to go through the whole HIPAA security issue, because essentially the patient has their own HIPAA security agent, which is this authorization server. So the coupled EHR that goes with this authorization server becomes the first what we call resource server, meaning the resources are the patient data. Now there could be a variety of different resources like OHSU or different organizations that pull into this as the patient aggregates. And one of the things that we were able to demonstrate in our HRE of one system from the get-go was the way to the ability to connect to an Epic institution. Because Epic recently put out something called Open Epic, which is a FHIR service where if a person or a patient has the right authentication to their MyChart, for instance, they can actually pull in data through FHIR into whatever app that the patient has set up. And in this particular case, we're using our patient authorization server as that app. And we were able to successfully pull in data if you have a MyChart account to Epic. And so we know that that works. And we're also working with Cerner currently right now through their implementation, because each of them are slightly different, but in terms of how much they're willing to open. But certain resources like medications, problem lists, allergies, those are all some of the basic ones that we were able to pull in from Epic. I talked about certain things like default policies that a patient can set up for their authorization server, so they don't have to do the work of authorizing each and every single physician if they choose to. So in terms of the blockchain component, one of the key things that our project is really adamant about is that we don't actually store any patient health information on the blockchain. So for example, this whole notarization idea that we talked about with this patient prescription. What we are utilizing in our demonstration is that, let's say a physician utilizes the EHR that the patient is serving up on their patient health record. And the physician writes a prescription for lisinopril. When it saves it, or when he signs it, basically a FHIR document, which is a JSON text file essentially, becomes hashed, and that particular document has basically the requisites of all the information that needs to be on the prescription in the FHIR format, and then that gets hashed, and then that hash gets sent over to the blockchain that basically says that this physician or this user signed a prescription at this particular time with this document hash. So let's say the patient has this prescription on their EHR. They're giving it to a pharmacy and say, hey, I have this prescription electronically that was signed by this physician. And then the pharmacy could then use an app that looks up this on the blockchain, this public ledger, and says, okay, this FHIR document that's in English, or you can kind of see it in English, but human readable. But then they hash it, or they compare that hash of that document to what's on the blockchain. And then if it matches, or if the hash matches, then it means that that prescription is legitimate, and it's not been tampered with. So so one of the people, a lot of people have asked, well, how can you prevent certain orders or prescriptions from not being tampered by the patient if the patient owns and controls their health record? Well, this is exactly what we're using blockchain for, is this notarization, digital notarization function. And this hash actually is not human readable, so there's no patient health information that's residing on the blockchain. It doesn't say who the prescription is for or who signed it literally on that hash. And so so agencies like the pharmacy in this particular example would be establishing or confirming trust with the prescription that the physician generated and that the patient presents. So this three-way relationship is yeah, absolutely.
Because Because that, you know, I think that's a concern that a lot of people have is, you know, the integrity of records, whether they're altered by patients or anyone else. So basically, you're creating a hash of this prescription that lives somewhere else, and then so when a patient presents with it, then it's
they would have to confirm that.
Confirmed against that
hash.
Okay,
right.
That actually seems like a pretty good use case for blockchain or other technologies that would do that sort of thing.
That's correct.
Yeah.
Right. And so, yeah.
So the only thing associated with a particular entity, like a patient or a pharmacy, is the timestamp.
Right. So there's a timestamp and the document hash that goes with that timestamp that signifies a particular transaction took place. And I already went through this about in terms of self-sovereign identification, which also uses blockchain technology using a smartphone with Touch ID. So that's the other part of it that we would use blockchain. And then also for the signing mechanism that I talked about, again, with that identity being verified by the physician, saying, okay, I'm a physician and I can sign this prescription. That gets integrated as a part of the blockchain transaction that gets saved. So, yep, I kind of went through that verbally. Any questions about the blockchain component with this EHR? So, in terms of benefits that we're proposing, we believe that this type of proposal will not necessarily alter or replace existing institutional EHRs. What we're proposing that this is something that works in adjunct to existing technologies, but to help solve this interoperability problem as well as the patient ownership of their healthcare data problem and security, which theoretically then potentially reduces redundancy of tests, for instance, errors, medical errors, and improving communications between the patients and the physicians. And then this also is a benefit for those providers that have their own independent practices that either don't have an EHR or they're not happy with their EHR. They'd rather use the patient-centered health record EHR. They can choose to do either one. And because of FHIR, they can, a physician that works at OHSU doesn't like their EPIC system, they can enter something on the patient health record, which then it would shuttle that information back when he signs that note to the EPIC, And in theory, that is, using FHIR would be a way to communicate or to send data from one container to the institution. And then what we envision is that we're creating a whole new application ecosystem where health apps are no longer needing multiple agreements with either a specific institution, a variety of institutions, or EHRs. And that's one of the challenges today if you're a health app provider or developer, that they have to go through these different channels to be able to have access to a patient or a patient population for whatever usage that they're needing. They can actually go through these patient containers, and the patients would then give the authorization for their data to be released if they choose to these health apps, and it'll be no longer this second or this layer of the health app having an agreement with an agency, but the patient has no say necessarily where their data is going to once that agreement is set. And then likewise, we can envision here where a health app could potentially get real-time feedback of the patient data, which could be a huge assistance in terms of both artificial intelligence and machine learning in utilizing data in terms of predicting certain types of disease models or being able to provide health activity-related feedback for the patient. And then we're also utilizing the system. We're encouraging the usage of these patient data to include things like social determinants of health that are starting to be talked about in health IT circles right now. And what we believe is that by having patients have more ownership of their data, this will further facilitate improvement of tracking these social determinants of health. For instance, things like family history and social history, physical activity, as being certain examples of that. And so with the HIE-1, we've got 2 pilot projects that we're currently are in the works of that are currently in the works. One of them is based in Austin, Texas. That is an HIE that right now doesn't have a fully functioning HIE, and they wanted something different, and that's why. And when they heard about our project, they wanted to include us in terms of facilitating a 300 physician group patient population that's served by the Texas Medicaid population.
I think most people know what an HIE is, but
sure.
Maybe not every last person.
Yeah. So HIE is Health Information Exchange, and the Health Information Exchange was born out of this idea of trying to solve the interoperability problem where, an institution has one EHR, a different institution has a different EHR, and how do they pull together the information so that eventually, hopefully, the patient will have a complete record, irregardless of the institution. But again, we talked about how there's challenges with things like patient matching, and a lot of them are struggling right now because of the lack of interoperability between existing EHR systems, and because patients really don't have much of a say in terms of how their patient is, or their data is up to date or correct or owned, if you will, by the patient once the HIE has integrated or conglomerated the different patient data for that one patient. So hopefully that makes sense, and that's why we called our project HIE-1. So instead of an HIE that serves thousands of patients, we're talking about an HIE that serves only one patient. So we're looking at it from a completely different angle. And then our second pilot project that we're also working with is in Atlanta, Georgia, and primarily working with the homeless population, trying to figure out how to utilize some of the self-sovereign identification. If they have a way to doing biometric and then digital health, digital or touch ID as a way to signify, okay, this patient, even if this patient doesn't have any identification with them in terms of paper identification, how do they make sure that that patient has a viable health record that spans different institutions wherever they may be or where they go. And so that's, so we're also building a pilot project with our system there as well. And so we're also, part of what I'm talking when I spoke with Dr. Hirsch was, since I was based out in Portland, I thought, hey, this was an opportunity to have people that know about this project to be a part of being able to think of some ideas of how we can show or utilize specific patient populations to see the utility and the usage of this particular system. Ideally, we would like every patient to be able to have this, but we know that to show viability and whether it actually works, we want to try to make sure that we can demonstrate that for a specific patient population that this has made a difference in their care by their physicians, and that the patients have better ways of utilizing their own healthcare data in the future. So that's the end of my talk. Hopefully I have a few minutes left, a little time. Yeah, so yeah, I'm open to any questions, and then, yeah.
It's actually not really a question, but
yeah.
It actually is in part a kind of validation of. So at the HIMSS meeting the other day, I saw actually some of these folks know Ricky Bloomfield from Apple, get up and actually do a demo where, and the next version of iOS, supports, the Apple Health app supports downloading Fire data. And so he actually, he was previously at Duke, and now he's out at Apple and wherever, Cupertino, wherever Apple is these days. And he has health records, at Duke and University of North Carolina and Dignity Health in California. And he actually he did a live demo how he had an iPhone 10, so he did the Face ID thing too. And he could pick and then authorize through OAuth 2 the data to come out of these Epic instances to his Apple Health app, which at least that kind of demonstrates. I don't know that necessarily the Apple Health app is where we ultimately want all of our data to reside, but it demonstrated that he could contact with Epic systems and pull the data in. So I mean, it's not a real far-fetched idea. In fact, I think as you probably know, assuming we continue meaningful use stage 3 and its certification, that will require to have that open API. So it was interesting to see.
Yeah, and that's a very similar thing that with our demo, where we were able to, like I said, if you have a MyChart account, that's essentially the OAuth 2 way to get into your data that goes through your authorization server. Yeah. Oh, go ahead.
I may have missed that, but are you using it in your own medical practice at the moment?
So my medical practice, well, the Portland Clinic uses Epic, so that I don't utilize that currently. With my old practice, I did, and so there's a number of small independent practices that are utilizing just the EHR component of NOSH. No one is currently utilizing the patient health record. I mean, essentially, once we deploy some of these pilots, I'll probably be one of the first ones to have my own for myself and my family. But essentially, the idea is that each patient would then deploy their own, essentially, web server for this. And then the medical providers can still utilize their EHR or utilize my EMR, essentially, to be able to interface with the patient health record if they so choose to. Yes?
Thanks for a great talk. I was just going to follow up on your question about population, like a use case populations. And the thing that popped into mind, the homeless population, I think is a great idea, but also just like kids in general, where you have like both parents or maybe grandparents or essentially any patient, right, where more than they're primarily reliant on caregivers or multiple caregivers specifically, so that you can, in high-use medical cases, just so you can actually like have, I don't know, you can have a better coordination and you're not throwing information everywhere.
Right. One of the things that we talked about in our project is utilizing an example for like cystic fibrosis and then for kids. And with this authorization server, technically a patient, even a child patient that has their own web server, basically can designate someone else to be their proxy to set authorization parameters. And then once they're of legal age, they can choose to revoke or change who has access or has the ability to set policies on their authorization server. Essentially, when I tell other physicians about this authorization server project, essentially this authorization server serves as a HIPAA agent, essentially, that governs these policies so that their healthcare data is securely getting to the right people that the patient has designated. So, yes.
Another unrelated question to the one before. So where I see that maybe open source EHRs could actually play a bigger role in the future is just by like taking what's already been invented by other open source EHRs and combining them, not reinventing the wheel about everything, using modular code, and thereby like saving the time to like reinventing it from scratch. So I was wondering, looking over your GitHub, do you collaborate with other ones like OpenEMR that I know about, or do you use things from Vista or whatever is out there, or what's the relationship? Is there an open source community, and what's the relationship?
Yeah, the open source community in terms of EHRs is unfortunately that it's got its challenges. In fact, I was one of the first. I collaborated, or I worked with OpenEMR at the beginning before I decided to make my own. And a lot of what I was when I first started to develop my EHR, what I was envisioning was primarily from a user interface standpoint. I was really a stickler on workflow, mainly because I had my own practice, and I wanted to make sure that the EHR worked for me in terms of how things flowed from a clinical perspective. And I found that it was hard because OpenEMR was not necessarily modular, that it was hard to change one thing without affecting everything else, and it was hard to put in requests that basically fundamentally changed the entire system. And so, because a lot of the user interface challenges relates to how the code foundation, if you will, or database foundation really is structured. And so that was one of the reasons why I ended up completely, overhauling or creating a whole new system. I wish it didn't have to be that way, but sometimes, those fundamental challenges become so great that it's easier to just create something new. Now, down the future, I think ideally, if there can be some increased collaboration or movement towards where different open source projects can pull together resources, that would be great. One of the EHR or the code base that I use is based on something called Laravel, which is an open source PHP framework, which has tons of contributors. And that was one of the reasons why I decided to use that, is that it's a good jumping point for other developers to, utilize or add or change or improve upon my code because it's on a framework that's familiar. And what I do is just adding or conglomerating different parts of that Laravel, the different Laravel plugins, if you will, to create what I made. So that was one of the other reasons why I decided to use that as a foundation for my code. And the authorization server basically utilizes the same framework as well. Yes?
I'm thinking about when you mentioned the HIE and the lack of patient control over the data. I really like the starting from the ground up. I wonder how many coders really start from this perspective of patient-centered. I think that's wonderful. I'm wondering how, in doing that, you're approaching patient input on their own record. Most specifically, I'm thinking of a use case of like medications. Let's say a medication list that's super messy. Stuff wasn't taken off, and docs don't have time, or and that happens all the time, right? And but then even something as simple as which document comes from where, and are they in their appropriate places?
Right. That's a great question. And one of the things that with this patient-centered health record is the ability to reconcile information both from a physician or patient input request. So like a patient says, well, I'm actually taking this medication in a certain way rather than what the physician has prescribed. Or I'm not even taking this medication at all. Or or this other physician from a different institution has recommended this prescription or this medication. And so there's a way in this patient-centered health record. There's a way for the patients to actually designate, say, hey, I would like to make an edit to this medication because this is how I'm taking it. It gets flagged, it gets saved, but it gets flagged as it needs reconciliation, meaning that it's something that the patient and another physician that they're working with has made a determination, yes, that is what they're doing. And so each time that a physician goes through it, they'll see, oh, there's certain things here that need to be reconciled. Is this true? And then once they flag it, or once they approve it, a physician signs off on it, then basically it shows up on the complete list. But you'll see both the patient and the physician will see that there's things that need to be reconciled. And when it's not and when it is all reconciled, then it's the up-to-date list, if you will. So. The EHR.
Okay, with the HIE of one, but then how does that can it communicate those types of activities and reconciliation type activities across the API to the different EHRs?
Theoretically, yes, but that's one of the challenges with how, the receiving end or the other institution, whether they will be, how they accept that and how do they reconcile it in their own records. Ideally, we theorize that this patient health record would be kind of the most up-to-date record over time as people start to utilize it, that will be kind of the main tool, if you will, primary database, if you will. Then everybody else will then eventually synchronize to it. But, so one of the challenges is obviously what's more current, and we have to start somewhere, and so that's why we have this reconciliation tool as a way to start that conversation, and then eventually this patient health record would theoretically be the kind of the designated resource, if you will, primary resource that contains the accurate information, which then would be pushed out to other EHRs if they will receive it. But that all depends on how the other EHRs will cooperate or not about that. So, yes.
Thanks, great talk. He actually stole my question, so I had to come up with another one. But I'm curious, it's not quite clear to me how exactly you plan to integrate this with current EHR systems. How are you going to be an Epic and then access this data? How is that blockchain authentication? How are all those processes going to work?
Yeah. So one of the, what I talked about with this Open Epic demonstration is basically being able to start pulling in data from different EHRs. So that's one way. Then to be able to push back would depend on, obviously, the EHR, like Epic, to be able to receive that information and integrate it in their own system. So that is something that is outside of our control, but our hope is that once patients say, hey, we are utilizing this, please, do this for us, and then that's up to them. But that's kind of how we envision where that interplay would go.
Do you envision maybe using some, if you built Fire apps within Epic, then these could kind of serve as that interface?
Right, and essentially the authorization server, like we talked about, is that Fire service, if you will, and the patient would log in through their MyChart account, essentially, as a way to get that data in. So the patients still ultimately have control. It's not the physician that's saying, I want to transfer this record, because then the patient, basically the patient is the one that controls that flow of information going back to their authorization server and to other institutions. So,
okay, thanks.
Actually, just so people know that there are people listening to the stream out there, a question over the Twitter feed. While I'm not an expert of security technology, I believe that there are ways that savvy hackers can find ways to work around the hashtag, or I think what she means is the hashing mechanism, or can break into a patient container. How vulnerable is the patient record if it exists on the network?
Yeah, and certainly those vulnerabilities we acknowledge exist, but because of the whole concept of distributed networking, we call it, imagine basically like a honeypot of data. So you have an institution that has thousands of records. A hacker could spend, 20 days trying to hack this one system, but the payoff is huge. They have thousands of records they can have access to, whereas if there's one patient container that exists out in the cloud that only contains one patient, and a hacker goes in and maliciously wants to get that data, they could, but they really only get that one patient data. And so unless you're super important and you're a celebrity, maybe you're vulnerable in that sense. And we can't prevent that, but in terms of overall, in terms of how we manage security, we think that the distributed networking model works better, and it actually improves the vulnerabilities of institutions, where basically institutions will say, well, I don't even need to have my own database anymore of thousands of patients. I can just rely on these patient health records. And again, that's an evolution that will happen. It's not going to happen overnight, but the idea is we want to move away from basically these data honeypots, if you will, and using this as a distributed network model is the reasons why we designed it, or why we thought of it in this way.
Although if you're that one person,
yeah.
I was actually going to ask another question, because actually some of our students here study bioinformatics, so they do a lot of genomics work, and I always like to try to engage them in these clinically oriented talks. So in the future, there may well be a time when all of us have our genome sequenced, and I suppose our genomes could, pointer out of the blockchain to the genome. And then in the precision medicine paradigm, we'll increasingly learn things about our genome that, we're at risk for diseases. There might be, certain treatments for disease that might work better because we have a certain gene variant. I mean, in a way, it's kind of a form of clinical decision support in the sense of, but distributed clinical decision support, because the data might be out here, the rules might be somewhere else. How do you see that? Do you see any problems with that use case in terms of what you're trying to produce here?
Not necessarily, and I think this again complements the existing, distribution of where the patient data is residing, because health apps, I'm just using that as a general term, or health services, they have a particular focus and they want to do that focus well. And they don't want to be the hold-all of everything, and so I think that's again with this technology, it encourages that type of development and production, and it doesn't rely on these institutions to try to come up with these agreements with different agencies and institutions across the nation to get their patient health data from the MyChart, for instance, to be able to provide the service that they're providing. And so things like the Genome Project, they can have just the part that pertains to patient A about this patient's genome, and that can be secure, but then everything else can reside elsewhere. But if someone wants to look at it in totality, for instance, or primary care physician, they can see all of that in theory, which then could make basically, in terms of clinical decision support, much more meaningful, because we're not just getting just pockets of data that maybe only have, one specific service or use case. We theoretically are pulling in data from any variety of health apps if, they've gotten the permission by their patient to use and to view that information.
Any other questions? Okay.
Oh, there's one back
Thomas.
there.
So if I understand you correctly, the blockchain will only contain the hashes of the transaction, but not the actual content. I think the main security risk there would probably be that somebody intentionally falsifies it, potentially by trying to recreate, I think the term is collision or something with the hash, with a different identity or prescription, for example, than intended. What's your take on which hashing algorithm to choose to minimize that risk?
Yeah. So in terms of the hashing algorithm that we currently use, we use SHA-2 as basically, basic as a way to do it. But certainly there's different ways that we could, improve upon that. We're just, with our demo, I think, there's definitely ways that we want to improve that security over time. As people become more sophisticated in potentially spoofing or hacking these hashes. But in theory, though, it takes a lot of work for an individual to try to do that for one particular, prescription. If we can talk about thousands of, order of thousands of orders, it would take quite a bit of work to try to do all of that in a malicious way. But there's always definitely room for improvement there. But we're using the idea of these hashes as basically a way that with these hash matchings, you can't, it'd be very difficult to alter the human-readable document and say, okay, this is, what's been notarized or what's been set on the public ledger. If there's no match, then the other agency knows that it's not valid. Yeah. So.
I just had a quick comment. So if you have, say, being represented as a JSON, and that's going to have defined key value pairs, and those are probably going to be set up in some sort of a data model that's standardized. What's interesting is that if you think about a prescription, what's in it, the contents, it's very vulnerable to a dictionary attack. because there are only so many medications. Names tend to get used pretty commonly, and maybe you have units of measure. And you can actually think about those like fields as like the alphabet. But one of the ways to inoculate yourself against that is to have a random component injected into that. And then that is shared across the FHIR instance, right? And when you compare hashes, you can't really do a dictionary attack against a random component. One of the interesting ways I've seen that done, like a true randomness component, I think Cloudflare, one of the ways they secure is with lava lamps.
Right.
So they have a camera that watches lava lamps, and those lava lamps are truly random because we don't actually control anything except the on and off switch.
Yeah.
And so that generating randomness that way may be one way to harden those records.
That's a great suggestion, and that's another reason why we like the open source way. Is we know that there's a lot of people that have great ideas about how to do this, and hardening and improving the security of the system definitely is one of our goals. So thank you.
Okay, well, I think we're time is just about up. Thank you all. This was actually a great conversation. This is definitely a hot topic. I'm sure Dr. Chen will stick around for a few minutes if anyone has any questions for him. So, thank you.
Thank you so much.